evening, ladies and gentlemen. It's a pleasure for me to attend this marvelous meeting. I would like to thank Dr. Ayman Fakhri and all the organizing committee for their kind invitation. I will talk about a challenging part in our practice, in our diagnostic practice of veins. How would we examine and how would we exclude patients with pelvic congestion syndrome? I have no disclosures about this aspect. So, patients with pelvic varicose vein, either asymptomatic, so we search for no treatment, or symptomatic, either they having symptoms of pelvic congestion syndrome associated with or varicose lower limb varicose veins, they seek treatment. So, pelvic congestion syndrome or pelvic varicosities are classified into three types. Type 1 corresponds to a valvular or parietal varicosities without pelvic or suprapelvic obstruction. Type 2 related to either stenosis or obstruction in the pelvic or suprapelvic regions. Type 3 other abnormalities which are associated with reflux secondary to local eccentric causes. Here's an algorithm of the management of these cases. The patient may present with parietal, genital, or inguinal varicosities, or atypical varicosities of the lower limbs, or symptoms of and signs of pelvic congestion syndrome. We examine the pelvic veins by color duplex, either normal, so we proceed to treatment of the lower limb varicosities. If it's pathological or positive finding, we have a suspicion of obstructive syndromes, we proceed to CTA or MRV, sorry. If non-obstructive, we proceed to pelvic phlebography and embolization if needed. So, what we examine in our duplex ultrasound duplex examination, we first start by examination of the pelvic parauterine area for varicosities. If we find, we proceed for examination of the gonadal veins. If we find pathology in the gonadal veins, we search for obstruction, either at the level of the left renal vein compression or the level of iliac veins. Then afterwards, we search for the leaking point of communication between the deep pelvic veins and the lower extremity veins, and we examine the lower limbs for valvular incompetence. The reflux is graded in a scale from 1 to 4. 1 is not present, absent. 2 is not significant. We call it mild intermittent reflux, lasting less than 0.5 seconds. Significant, it is a persistent reflux during the whole physical maneuvers, which we will talk later, or reflux more than half a second, or very significant passive or spontaneous reflux lasting past the physical maneuvers. We find another associated findings in our examination. We may find the ovarian veins are dilated more than 6 millimeters in diameter, or we find pelvic varicoses, dilated parauterine or parametric veins, at least 4, and the diameter of the veins is more than 4 millimeter. We find a contralateral ipsilateral siphon effect between the ovarian veins and the interior iliac veins. Also, the varicoses show a venous reflux during physical maneuvers. How we examine the pelvic veins? We have different approach. We have a trans-abdominal approach, a transperineal approach, which is more better than trans-abdominal because we exclude the motion artifacts by abdominal motility during respiration, and most detailed study by transvaginal approach. Here is the transvaginal approach. Here's how we introduce the transvaginal probe into the vaginal cavity till we reach the cervix. We firstly examine the uterus in axial view. Here the uterus, here the endometrial cavity. You find surrounding parameter dilated veins, and when applying color Doppler, we find venous reflux during different phases of respiration. Then we incline the probe to the right and left fornix of the vagina to examine the ovary, the ovarian vein, and the paraovarian vessels. Here we see a very dilated ovarian vein showing a very significant reflux. Then the transabdominal approach. We can here examine the uterus in the pelvic cavity. In the coronal section, we can find a right-sided varicosities or a left-sided varicosities. And when applying color Doppler, we can here see a venous reflux during inspiration or expiration. Also, we can see here dilated arcuate veins crossing the flow from the right to left. Here's some of my cases. We can see here there is dilated para-uterine veins more than 6 millimeter. Also, during inspiration and expiration, there is color filling of the veins, denoting venous reflux within. Then we proceed to examination of the gonadal veins. We examine by transabdominal approach. Firstly, we examine the veins above the umbilicus in a sitting position, like 80 degrees recumbent position. Then when we examine the pelvic veins, we change the position of the patient to 45 degrees inclination. We use a Kelvin probe, 3.5 megahertz. We use the high resolution as we can adjust the machine. We also reduce the PRF, what we call the scale or the velocity, the lowest as we can. As we all know, the anatomical course of the ovarian veins, the right ovarian vein drain in the IVC in acute angle, while the left ovarian vein drain in the left renal vein in a more right angle. So according to this anatomical difference, it's more likely to have a venous reflux into the left ovarian vein. Here we can see the examination of the ovarian vein more proximally in the abdomen. After the origin of the vein, we can see it in transverse section. Here's the psoas muscle, here's the ovarian vein, and the aorta and IVC. More distally toward the pelvis, we can see here that the ovarian vein is moving toward the midline to cross the iliac veins. The origin of the right ovarian vein and the left ovarian vein, we can see here that the left ovarian vein is dilated. Here's a huge ovarian vein appearing tortuous and dilated, associated with multiple collateral veins. Reflux in the left ovarian vein. Here is one of my cases. We can see here the right ovarian vein is with normal caliber, while the left ovarian vein is dilated, showing reflux. A real-time imaging of this vein, we can see with respiration, there is reflux in the vein. Also, divided into type 1 without obstruction, type 2 with obstruction. So examination of the left renal vein, we try to exclude the nutcracker syndrome. We have 3 types. The most common type is compression of the left renal vein between the superior mesenteric and the aorta. The less common is posterior form, which is compression of the left ovarian vein between the aorta and the vertebral column. And the rare form is circumaortic left renal vein. Also, the same parameter we use in our examination. So the most important trick and tip, we do the examination, we do not perform external compression by the probe. If we perform external compression, we have a pseudo nutcracker appearance. Here we doing a compression. You can see here that the left ovarian vein appear narrowed, while with the right pressure, the caliber of the vein retains normal pattern. So it's very important to lightly examine the patient with no pressure to reach the diagnosis of the nutcracker syndrome. The difference between the diameter of the vein near the kidney to the mesoaortic area must be 5:1. Here's a sagittal view of the crossing of the renal vein in the mesoaortic space. We can see here the angle between the superior mesenteric and the aorta must be more than 30. If less than that, we can suggest the presence of left renal vein compression. The physical maneuvers to exclude pseudo nutcracker is by firstly changing the position of the patient from supine position to lateral decubits, either right or left, or using a trended bank position to increase the flow in the renal vein and expand the vein. Also with deep inspiration using Valsalva maneuver, but the Valsalva maneuver may exert some motion artifacts and we can lose the appearance of the vein. Here's a pseudo nutcracker. By moving the patient to a lateral decubitus, the vein retained its normal diameter. One of my cases is an evident narrowing of the renal vein in the meso-aortic region and dilatation of the vein proximally. And by Khaled Doppler, we can see here a very high jet of flow, denoting compression. But when I perform a lateral decubitus position, the vein returns to normal caliber with loss of the aliasing and jet here. So it's to diagnose and reach a diagnosis of left renal vein must be very cautious. Very rare pathology, and not every case you have to diagnose with this. Examination of the iliac vein to exclude May-Turner syndrome. As we all know, the May-Turner syndrome is compression of the left renal vein by the right, crossing by the right, left common iliac vein by crossing of the right common iliac artery. We have indirect signs to suspect this. When examination of the common femoral vein, we have a low flow, a low speed flow in the common femoral vein with loss of respiratory physicity on the left side, so we can suspect the presence of May-Turner syndrome. Also, we can see reflux or reversal of flow in the ipsilateral left internal iliac vein, and we can find some collaterals around the iliac vein. Also, the same principle, don't exert any pressure while examination of the iliac veins. One of my cases, we can see here there is compression of the left iliac vein by the right common iliac artery. Here the aliasing or the jet flow due to this compression, and it's continuous. And when we do a spectral waveform, we can see a very high flow reaching 100 centimeters per second, denoting the presence of May-Turner syndrome. Here's a refluxing left internal iliac vein. So searching for leaking points, which is the points of communication between the pelvic varicoses and the lower extremity varicoses. We have 5 common types: the perineal P points, the inguinal start with the gluteal points, the superior gluteal point and inferior gluteal point, perineal point, obturator points, inguinal point, and the 6th point was described later, the clitoral leaking points. Here is the B point, the most common type of leakage in the pelvic congestion syndromes. Here is the inguinal point and associated with anterolateral thigh varicosities, the most common cause of this type of varicosities. But the superior gluteal and inferior gluteal and obturator cannot be detected by ultrasound because they are deep seated points. Here's the appearance of valvular varicosities, and this ultrasound image of this varicosities, we can see dilated veins. So I would think this is must be my first slides. So how we suspect the presence of pelvic varicosities when we do or perform an examination of lower extremity varicosities? Either the presence of varicose veins in the upper proximal thigh, which is a typical type, a typical pattern of varicose veins which are not associated with truncal varicosities, and an recurrent varicose vein. Here is one of the cases. We can see here there is reflux in the great saphenous vein, but not due to junctional reflux, but a vein coming from the pelvis, perineal or vulva. Also reflux across the anterior accessory saphenous vein due to refluxing posteromedial valvular varicosity. Also, if we have a posterior thigh varicosities due to reflux at the perianal region, refluxing into the vein of Giacomini and going to the small saphenous vein. Also, we can find the posterior lateral thigh varicosities. In the recurrence, if we do a high ligation of the great saphenous vein and we find the reflux in the great saphenous vein, residual great saphenous vein by perineal vein. Also, if we have great saphenous vein stripping with high ligation and we find reflux in a new vessels in this region, we can suspect pelvic congestion disorder. So it's a very important part that we must include in our study, performing examination of the lower extremity varicosities. If we suspect the presence of pelvic congestion, we must search for these points. Thank you very much.